So it's really a privilege to talk today on the program about available data with and the current and future role of bispecific antibodies in multiple myeloma. And I'm Hans Lee from MD Anderson Cancer Center. I'm a multiple myeloma specialist, where I see exclusively patients with multiple myeloma and also the director of multiple myeloma clinical research here at MD Anderson Cancer Center. So I thought we'd begin by discussing a case of a patient who was a candidate for a bispecific T-cell antibody that I saw in my clinic earlier this year. And then we'll be talking a little bit about the supporting data regarding bispecific antibodies throughout this program. So this was a 38-year-old gentleman with relapse refractory multiple myeloma. And the patient was diagnosed several years ago with initial presentation of diffuse bone disease and multiple lytic bone lesions. And the patient did have high-risk disease at initial presentation with translocation 414. And so the patient was initially treated actually in an outside facility with cyclophosphamide, bortezomib, and dexamethasone for 1 cycle, followed by bortezomib, lenalidomide, and dexamethasone for 4 cycles with a partial response to therapy, followed by high-dose chemotherapy and autologous stem cell rescue with further deepening of response to a very good partial response. And then the patient then proceeded with lenalidomide monotherapy maintenance therapy with continued very good partial response, but ultimately had progression of disease actually just after 1 year after starting maintenance therapy. At this time, the patient was then referred to MD Anderson, and the patient was then treated with daratumumab, bortezomib, and dexamethasone for 3 cycles, followed by daratumumab, ixazomib, and dexamethasone on a clinical trial that we had here at MD Anderson. With the best response of stable disease, then patient had disease progression. And then for line number 3 of therapy, the patient was then treated with carfilzomib, cyclophosphamide, and dexamethasone with a partial response. But this response was very short-lived. It only lasted a month, actually. And then the patient had rapidly progressing disease with not only biochemical progression, but also clinical progression with new lytic bone lesions, multiple fractures, and actually epidural spine disease that required radiation therapy. So in summary, this is a 38-year-old gentleman with relapsed refractory multiple myeloma. The patient is triple-class refractory to bortezomib, ixazomib, carfilzomib, lenalidomide, and daratumumab, also refractory to the alkylating agent cyclophosphamide. And so really at this point, the best option is a BCMA-targeted therapy for this particular patient. But because of the patient's rapidly progressing disease that I mentioned earlier, doing a BCMA CAR T therapy was not a practical option at this time, given the time to allocate a slot, apheresis, manufacture, and infuse the cells. And so the decision was then made to proceed with standard of care teclistamab, which is a BCMA bispecific antibody currently FDA approved. So the patient received teclistamab standard of care as an inpatient, and the patient received teclistamab step-up doses on days 1, 4, and 8 as in the hospital. And the reason why the day 7 dose was delayed to day number 8 is that the patient did have grade 1 CRS with a fever on day 6 and day 7. And this resolved with a single dose of tuzolizumab quite rapidly thereafter. So the patient then received the target dose of teclistamab on day number 8. And the patient has been doing well and continues on therapy. And so the patient is currently mid-cycle 4 of teclistamab with weekly dosing. The patient has a partial response to therapy so far, with the ongoing duration response of 4 months. And I provide a little snapshot of the patient's paraprotein levels actually that we're seeing so far in this patient. So you can see that the patient's previous therapy prior to teclistamab was carfilzomib, cyclophosphamide, dexamethasone. Again, a very short duration of response lasting about a month before progression. And you can see that with teclistamab dosing, you see this decrease in the paraprotein levels, and actually that continues to decrease with time. So just a few words on BCMA, since a major topic of this program is BCMA bispecific T-cell antibodies. And so BCMA has emerged as a very important target for the treatment of relapsed refractory multiple myeloma over the last 5 to 7 years or so. And the reason why BCMA is an attractive target in multiple myeloma is that it's nearly exclusively expressed on mature B lymphocytes, in particularly plasma cells or multiple myeloma cells. It also has biological relevance as well. And so upon binding to BCMA by its ligands, primarily APRIL and less commonly BAFF, this then triggers a cascade of signals that leads to the growth and survival of long-lived plasma cells or multiple myeloma cells. And so the initial approval of the BCMA bispecific antibody teclistamab was based on the pivotal phase 1, phase 2 Majestic-1 study. And so the phase 2 portion of the study enrolled 125 patients, including the phase 1 patients treated at the recommended phase 2 dose. 165 patients were treated at the recommended phase 2 dose of weekly teclistamab subcutaneously 1.5 milligrams per kilogram. And notably, patients with a confirmed complete response or better for at least 6 months in the phase 2 part of the study could switch to every other week dosing from the weekly dosing schedule. And so what the results show was that the efficacy of teclistamab therapy in largely triple-class refractory multiple myeloma patients was quite impressive, with an overall response rate of 63%. And the majority of patients who attained a response attained deep response, with 59% of patients attaining a very good partial response or better. And notably, one thing that we have noted, generally speaking, with bispecific antibodies as a drug class is that while we are seeing very high response rates across the board, we are seeing somewhat diminished responses in some historically high-risk subgroups of patients, including patients with ISS stage disease, high bone marrow plasmacytosis, and extramedullary soft tissue disease. In terms of the durability of responses, actually, updated data was presented at the ASCO meeting with nearly 2-year follow-up with teclistamab from the Majestic-1 study. And the median duration of response was 2 years. The median progression-free survival was 12.5 months. And actually, data from patients who made the switch from weekly to every other week dosing after attaining a complete response for at least 6 months was also presented. And the median duration of response after the switch was 20.5 months from patients that switched from weekly dosing to every other week dosing, really providing rationale to de-escalate the frequency of dosing in those patients that attain a deep response to therapy.
So just a question that sort of popped into my head as you were going through the data. How would you indirectly compare the efficacy parameters that have been reported, PFS, response rate, et cetera, of BCMA bispecifics in general, or teclistamab and CAR-T?
Yeah, this is a great question. It's something that we always do when we look at the data, even though we're not supposed to compare studies, across studies. But I think this is something that we naturally do, and something that is also very much taken into consideration when considering one drug versus another. I think that in general, if you just look at the numbers, we're seeing higher overall response rates with, for instance, cilta-cel, which is one of the BCMA CAR-T therapies approved by the FDA, with response rates exceeding 95% and progression-free survival exceeding 2 years with a single dose of cilta-cel. So generally speaking, the response rates do seem to be greater with CAR-T therapies compared to bispecifics. I think the one caveat, though, and I think something that we also discussed, is that the patient selection also matters significantly, I think, when it comes to these single-arm phase 2 studies. And so there is an inherent selection bias when it comes to CAR-T studies, like I mentioned on this particular case that I presented, in patients with rapidly progressing disease, with maybe perhaps biologically more aggressive disease. They may not be candidates for a CAR-T study just because it takes too much time to actually collect T cells, manufacture, and infuse. And so in that case, something off the shelf like a bispecific would be more appropriate. And so perhaps more patients with more rapidly progressing disease, kinetically progressing disease, perhaps are enrolled in some of these bispecific trials versus the CAR-T studies. And so there's probably some not only bias in patient selection, but also screening bias too, in terms of when I see a patient in my clinic, there are certain patients I would probably not consider for a CAR-T therapy just from their rate of disease progression. And so I won't even screen a patient for that type of study like that. So overall responses are generally higher in CAR-T, although I think the caveat is patient selection.
Yeah, I guess the question would be, and I don't know, I don't know if there are trials randomizing between CAR T and bispecifics, but if there were, and I don't even know how you design it exactly, but what do you think you would see? And I guess maybe there's not a long enough follow-up. I sort of had, maybe this is just a carryover from lymphoma, but I sort of had the opinion there was more of a plateau with CAR T, although maybe that's not the case. You tell me.
Yeah, so at this point, there does not seem to be a plateau with myeloma CAR T therapy yet, although the durability response in responding patients to cilta-cel, for instance, is very encouraging. And so I guess we'll get longer follow-up with that as time goes on. I think definitely there is not a plateau with ide-cel. And so generally speaking, the response rates and the progression-free survival seem to be shorter, at least from the KarMMa study compared to the CARTITUDE studies, although again, there are caveats with doing cross-study comparisons in that sense. But back to your original point of if a study would be done, I think, of course, the analysis would need to be done by intention to treat. And so, randomizing patients up
Right,
front, basically. And,
right,
some patients may not make it to CAR T due to rapidly progressing
right.
disease, but that should still, count in the denominator, for instance, of patients in their overall response rate, for instance. But I think practically speaking, that would be a difficult study to do. And I'm not sure that there would be one beyond, for instance, a cooperative group setting, for instance.
So, and I guess the other related question is a little bit getting off on a tangent, but just kind of curious which is if there is a difference, between response rate with ide-cel and cilta-cel, which there seems to be, is there a rational explanation for that?
Yeah, I think that probably the most common explanation that's given is that with cilta-cel, there's two BCMA binding domains on the actual CAR T construct versus one BCMA binding domain on ide-cel. So whether that leads to greater potency and efficacy of the CAR T construct with cilta-cel versus ide-cel, that's one possible explanation. I think that some of the real world data that has been presented, though, and actually real world data has been published with ide-cel. I recently published in the JCO, and actually the first real-world data from the U.S. CAR T Consortium was presented at ASCO this year. We're seeing great outcomes, I would say, in the real-world experience with cilta-cel. Although I would say probably the difference of sort of what we've seen between the KarMMa and CARTITUDE trials might be a little bit less in the real world than what the trial shows. So I think this speaks to perhaps some patient selection that, of course, can impact responses of these small studies.
Also, I guess another question would be what's again, I know it's kind of getting a little bit far off, but we can get into this with the webinar too, which is what's the ideal sequence, bispecifics to CAR T or the reverse? Any trials that are going to address this? Any hypotheses about what would be the ideal sequence? I guess people sort of feel like CAR T is going to have the greatest chance of maybe a longer term response and want to go with that first. But any thoughts about the optimal sequence, assuming you had somebody who could tolerate both?
Yeah, I mean, I think that if access is not an issue, so if a CAR T therapy was immediately available for a patient, and the patient could actually get the CAR T, perhaps due to more indolent progression of disease, a CAR T option is really nice for patients just because it's a one and done in terms of the quality of life, being off therapy, for hopefully many months, maybe years. And so, I can say that the patients who have responded well, who've received a CAR T, I think that it cannot be understated. So I think that, this is a very good option. And I think we're also getting some data now regarding responses after CAR T or bispecifics or vice versa. And so I'll talk a little bit about the data about responses to BCMA bispecifics after CAR T therapy. But at least I can speak to there was some real world data presented at ASH last year of the responses of bispecific antibodies or just in general BCMA target therapies after BCMA CAR T therapy. And the responses were not very, very good. And so, basically lower response rates, but also especially lower durability responses as well. And so I think right now the thought is that if you have both options available, you're going to have better responses by doing CAR T first, followed by bispecific, then vice versa. in that particular sequence. But again, we need more data on this. And, it may speak to perhaps some of the mechanisms of resistance, which we don't, again, know a whole lot about. But, one possibility is that, if you're on a continuous therapy with a bispecific T-cell antibody, it leads to more selective pressure on the myeloma clone, can lead to a higher incidence potentially of mutations or deletions of the BCMA antigen on the myeloma cell. And so perhaps, that could be a more impactful or a more common mechanism of resistance than that occurring in CAR T therapy, which is actually a very rare event.
All right, please continue.
So the second case I wanted to discuss was another patient I saw in my clinic. And this is a 66-year-old woman with relapsed refractory multiple myeloma, and she was diagnosed several years ago with initial presentation of anemia. And the patient also had high-risk cytogenetics on initial presentation. The patient had gain of 1q21 with one extra copy of CKS1B. And the patient did also have deletion 17p on conventional cytogenetics corresponding to loss of p53. And the patient received bortezomib, lenalidomide, and dexamethasone for 5 cycles with a partial response to therapy, followed by high-dose chemotherapy and autologous stem cell rescue with a very good partial response to therapy. And then the patient then proceeded with lenalidomide and elotuzumab maintenance therapy on a clinical trial we had here at MD Anderson. And the patient continued with a very good partial response to therapy, but then actually had a relatively short duration response with progression of disease, actually 20 months after initiating maintenance therapy. For the patient's second line of therapy, patient then was treated with an all-oral regimen of lenalidomide, bortezomib, and dexamethasone, mainly because the patient did have a preference for an all-oral regimen. And the patient had a minor response to therapy or minimal response to therapy, followed by progression of disease with a duration response of 9 months. And then the patient was treated with daratumumab, pomalidomide, and dexamethasone with a partial response to therapy, which lasted 32 months, followed by disease progression. And for line 4 therapy, a patient was then treated with carfilzomib, cyclophosphamide, and dexamethasone with a partial response to therapy, then disease progression with the duration of response that was much shorter of 7 months. So this is a patient with 4 prior lines of therapy. The patient is pentarefractory. So the patient is refractory to 2 proteasome inhibitors with carfilzomib and ixazomib, 2 immunomodulatory agents with lenalidomide and pomalidomide, anti-CD38 monoclonal antibody with daratumumab, as well as elotuzumab and cyclophosphamide. So in this patient, again, a BCMA targeted agent is the best option for the patient. Unfortunately, at the time, there was no standard of care BCMA CAR T slot available at the time for the patient. The good news is that we did have a clinical trial, though, with the BCMA bispecific T-cell antibody, and the decision was then made to proceed with linvoseltamab, which is an investigational BCMA bispecific T-cell antibody on a clinical trial. So the patient received linvoseltamab, and the step-up dosing for linvoseltamab is a little bit different than teclistamab. So the step-up dosing is done 1 week apart. So it's given on days 1 and day 8, and the target dose given on day 15, with inpatient monitoring for 24 hours after day 1 and day 8 of the first 2 step-up doses. And the patient had no CRS or ICANS and did very well during the step-up period. Per protocol, a patient then de-escalated from weekly dosing to every other week dosing starting cycle number 3. And then once attaining a very good partial response by cycle number 11, patient then de-escalated to every 4-week dosing per protocol. And over time, the patient had continued deepening of response and actually attained an MRD negative complete response by cycle 15. And the patient remains on therapy, MRD negative CR, with an ongoing duration of response of 16 months. And I think what makes this case quite remarkable is that, this is the patient's 5th line of therapy. She is pentarefractory to therapy, and her best response to therapy has been a very good partial response. And she has never attained a complete response to therapy. But finally, at line 5, with a BCMA bispecific T-cell antibody, she has attained an MRD negative CR. So the patient, as you can imagine, was quite excited about this, and with an every 4-week dosing frequency, which is fairly manageable for the patient. And so this really just highlights the profound efficacy of bispecific antibodies in general, and the specific linvoseltamab in this particular case. So just a few words on linvoseltamab. So linvoseltamab is being studied in the Linker MM1 study. This is a phase 1, phase 2 study of linvoseltamab and relapsed refractory multiple myeloma that's enrolling largely triple-class refractory multiple myeloma patients. And updated data with linvoseltamab was presented at ASCO this past month. And as mentioned earlier, patients on this study received step-up dosing with linvoseltamab at 5 milligrams and 25 milligrams 1 week apart, with a 24-hour hospitalization after each of the first 2 step-up doses. And then patients were then randomized to either receive 50 milligrams or 200 milligrams of linvoseltamab for cycles 1 through 3, which was then further de-escalated to every other week dosing starting cycle number 4. And then patients could then further de-escalate to every 4-week dosing in a response-adapted approach if attaining a very good partial response or better, and then 200 milligram cohort starting cycle number 6. So the overall response rate from the Linker MM1 study demonstrated an overall response rate of 71% at the recommended 200 milligram dose. And what was encouraging is that an overall response rate of at least 50% was seen in some of the historically high-risk subgroup of patients, including patients with extramedullary disease, high-risk cytogenetics, and high baseline soluble BCMA levels, although responses were diminished compared to those patients without these high-risk features. And then follow-up is a little bit shorter for this study compared to teclistamab. So at a median follow-up of 5.6 months in the 200 milligram cohort, the median progression-free survival has not been reached. Yet the 6-month progression-free survival was 73% in the 200 milligram cohort. So I did want to mention to you that there are a number of BCMA bispecific T-cell antibodies currently in clinical development for relapsed refractory multiple myeloma. This is a table that summarizes updated data to date presented at various meetings and publications of these different constructs. And as you can see, notably, what's highlighted or shaded in gray here is the AMG 420 and AMG 701, which are being developed by Amgen, are no longer currently in clinical development, so hence they're shaded in gray. But again, there's a number of other bispecific T-cell antibodies targeting BCMA that are currently in clinical development. I think some of the key points from this table is that the route of administration can vary. Some are subcutaneously, some are given intravenously, but we're seeing over response rates usually between 60 and 75% for all of these bispecific T-cell antibodies. And so again, high over response rates, and majority of patients who achieve a response also have deep responses with very good partial response or better. CRS is common, so CRS is a common event, but high-grade CRS is rare, and neurotoxicity is also rare. And the constructs of these agents can vary slightly as well. So some of these bispecific antibodies have, for instance, 2 BCMA binding domains like alnuctamab and ABV383. For instance, ABV383 also has an attenuated C3 binding domain on the T-cell receptor. So actually it's given with no step-up dosing up front, starting with a target dose on cycle 1, day 1. So there are some slight differences in the constructs of these agents, but also a lot of similarities as well. So I did want to spend a little bit of time talking about elranatamab because it does have also more mature data, and as a BCMA bispecific antibody currently undergoing FDA review for potential regulatory approval later on. And so the MagnetisMM-3 study was a phase 2 study evaluating elranatamab in relapsed refractory multiple myeloma patients with 2 different cohorts. One cohort in patients who are BCMA naive, and cohort B, which included patients who had exposure to a prior BCMA targeting agent. And elranatamab was also given in a step-up dosing fashion to mitigate CRS, with step-up doses given on days 1 and day 4, with 48-hour hospitalization after the first dose and a 24-hour hospitalization after the second dose, followed by weekly elranatamab thereafter. And patients who had a partial response after cycle number 6, lasting at least 2 months, could then switch to every other week dosing per protocol. So the efficacy of elranatamab was also quite impressive, with an over response rate of 61%, a very good partial response rate or better of 55%. As seen with the other BCMA bispecific constructs, there does seem to be diminished responses with patients with historically high-risk features, including patients with high baseline bone marrow plasmacytosis, ISS stage 3 disease, and extramedullary disease. In terms of the duration of response and progression-free survival, updated data was actually presented at the EHA meeting last month with a 14.7-month follow-up period. And the 12-month median duration response was 74%. The 12-month median progression-free survival was 57%. And patients who transitioned from weekly dosing to every other week dosing maintained or improved response at least 6 months in 80% of the patients. So I want to switch gears, or actually I want to talk a little bit, talking about your earlier question, Neil, about the responses to patients with prior BCMA targeted therapy. And so this kind of speaks to the sequencing of therapy.
Before you get into that, I was sort of just trying to think when you put that table up with all the BCMA bispecifics, I was kind of trying to figure out, like, are all of them going to take the same regulatory path that teclistamab is on? You know, the single arm initial approval and then randomized approval, and then what it's going to be randomized against?
Yeah, that's a great question. So I think this is, of course, up to the regulatory agencies and what they would deem acceptable. But I think, as far as right now, these agents are taking the accelerated approval pathway of a single arm phase 2 study followed by a confirmatory phase 3 study later on. And, there are confirmatory phase 3 studies going on, for instance, with teclistamab, comparing teclistamab with standard of care triplet therapy, for instance, in earlier relapse refractory multiple myeloma, for instance, in patients with 1 to 3 prior lines of therapy. And so I think these study designs will be probably very similar to the approach that were taken with ide-cel and cilta-cel with the recent readouts of KarMMa-3 and CARTITUDE-4 of, again, comparing these novel agents with standard care triplet myeloma therapy in patients with 1 to 3 lines or 2 to 4 lines of prior therapy.
Do you think there'll come a point when there'll be trials comparing two bispecifics?
I think that I would say probably from an industry sponsor standpoint, I think that would probably be less likely to occur. But if there was one, it would probably be done probably as a cooperative group study, for instance, where one bispecific antibody could be compared to another. I would say that probably in reality, though, the likelihood of comparing one versus another, I think, would be less likely, probably because they're probably more interesting trial designs and questions to ask than comparing one versus another.
Yeah, and I know you're going to get into a lot of the combination studies, which really look exciting. But no, I was just kind of thinking in general about how they do these things. It kind of reminds me of all the studies in CLL comparing everything to chlorambucil. Like in these studies, when you get that far out, how does the control arm do?
Yeah, I mean, I think that I do think that generally speaking, the ship has sailed when it comes to using doublets, for instance, as a control arm. So I think there's been a lot of use of doublet therapies. For instance, pomalidomide dexamethasone has been a very favorite comparator arm for a lot of these phase 3 studies with novel agents. And I think there's less of an appetite. And frankly, I would not be personally very interested in doing a randomized phase 3 with a doublet, such as a pomalidomide and dexamethasone. But I think the bar has been made higher, and so at least doing a triplet based combination as a standard care arm would be important. So I think that is evolving. I think and again, most of these phase 3 trials, which I'll summarize, I think in a subsequent slide, do use triplets as a standard of care arm. I would say, though, I think in reality, theoretically speaking, if several of these agents do get, let's say, regulatory approval by the European agency or FDA, the question is, how do we choose which bispecific to use? And so I think, in thinking about these things, of course, we look at efficacy. So, as a practitioner, we look at efficacy, and if efficacy is fairly similar across the board with 60 to 75% response rates, then we look at safety. And so, I think we want to see if there's any differentiating factors when it comes to cytokine release syndrome or neurotoxicity. And so, there could be some differentiating factors that are emerging with some of these different agents. And then if, let's say, safety is similar, then it comes down to convenience or the logistics of actually administering the drug. And I think, one of the things that has been kind of interesting, I think, in my personal experience with teclistamab so far, is that we are we certainly are giving teclistamab at a major academic center like MD Anderson, for instance, and I think this is being widely used across the board in the United States at major academic centers. But I think there's been less uptake in the community, and I think that in the future, I think trying to find out ways how we could, for instance, make it practically easier to administer for community doctors as well, I think would be important to look at, and of course is a future direction. And so I think there's probably less of an appetite for the hospitalization period that's required, for the step-up dosing. And so again, I think those bispecifics that have, for instance, a greater or perhaps better safety profile when it comes to CRS, but also an easier logistical administration sort of process, I think also will play a very important role in the future.
Well, let me ask you, let's just say for teclistamab, what do you think the biggest obstacle is? And I guess one question I wonder about is how much of a hassle is it to have tocilizumab available in a community oncology setting? Is it just another drug, or is it really, because to me that seems like one thing that maybe, I don't know that most oncologists carry that.
Yeah, and that's a great point that you bring up. And so I think some of these smaller practices, especially at smaller hospitals, may not have tocilizumab readily available. And interestingly, in the package insert with teclistamab, there's no mention of an IL-6 antagonist like tocilizumab actually in the package insert. And so another sort of way to easily manage CRS would be giving dexamethasone or corticosteroids as well, which is, I think, often used. And so there are other ways you can manage CRS if it were to occur. But I do think that I think the management of cytokine release syndrome may not be as common, I would say, in the community setting compared to an academic setting that gives bispecific or CAR T therapies. And also, a hospital bed availability may not be readily accessible either. And so you have to sort of,
Right.
at least for the current teclistamab recommendations, is to require hospitalization for 48 hours after each of the first 3 step-up doses. And so I think that's probably a reason why there's been less uptake perhaps in the community. But I think those things will change. I think, there are strategies exploring mitigation of CRS, for instance, pre-treatment tocilizumab, there's some data with that showing a decrease in the CRS incidence. And I kind of think of it this akin to the early days of daratumumab, where intravenous daratumumab was actually very difficult actually to administer initially.
Right.
It was a very long
Absolutely.
infusion if you can, and there's high infusion-related reactions, and and eventually the community did split dosing daratumumab, and so basically they would split up the dose between 2 days, and that was one way to mitigate that. And then eventually sub-Q dara was unveiled, and now we won't think twice about giving dara, either whether that be in academic settings or in the community settings. So I think these issues will be solved. I think these are the early sort of growing pains that we're experiencing with the adoption of these novel therapies. But I think hopefully in 5 to 7 years, we'll be looking back at this like, okay, well, it was tough back then, but we have a much better feel and handle of it now.
No, that's a really good point. I remember all the stories I was hearing when Dara first came out. I mean, the infusion rooms weren't open long enough, et cetera, et cetera. It's a really great point. Please continue.
So I want to talk a little bit about data of BCMA bispecific antibody therapies in patients with prior exposure to BCMA targeted agents. And we do have some data that has been presented now at recent meetings. And so the Majestic-1 study with teclistamab did have a cohort that did allow prior BCMA targeted therapy, including patients with prior BCMA antibody drug conjugates and also prior BCMA CAR T therapies. And what was encouraging was that in patients with prior BCMA targeted therapy, the overall response rates were quite encouraging, with responses exceeding 50%, whether that be with an ADC or with a CAR T therapy. I think one thing that we don't have as much from this data set is the duration of response and the progression-free survival. And so that data will be, of course, weighted in the future. But at least in terms of overall response rates, we are seeing very comparable overall response rates compared to the overall Majestic-1 cohort of patients with an overall response rate of 63%. Similarly, there was recent data actually presented at ASCO of a pooled analysis of alrantumab administered in the MagnetisM-1, MagnetisM-2, MagnetisM-3, and MagnetisM-9 studies. And so these are basically studies that did allow cohorts of patients with prior BCMA, ADC, or CAR T therapies. And what you can see here is that the overall response rate was a little bit less in patients with prior BCMA ADC, 42% versus BCMA CAR T, which is 53%. And the median progression-free survival was lower than those, again, without prior BCMA therapy at 5.5 months. Although I think what was kind of striking was that the patients with prior CAR T therapy actually, interestingly, had a higher PFS compared to those with prior BCMA ADC therapy. And so I think this kind of speaks to the fact that the CAR T therapy being a one and done therapy, the mechanism of resistance may be different, for instance, than patients getting continuous BCMA ADC therapy at the time of progression. And the median duration of response also seemed to favor that of the BCMA CAR T as well compared to ADC. So the next sort of segment of this program is an area where I'll discuss non-BCMA targeting bispecific T-cell antibodies. And so one emerging target in the last 3 to 5 years has been GPRC5D, and this was largely from work done from Eric Smith when he was at Sloan Kettering in discovering GPRC5D as a target in multiple myeloma. And so GPRC5D is an attracted target in multiple myeloma because it's highly expressed on plasma cells and multiple myeloma cells, with very little expression on non-plasma cells or myeloma cells, except for the hair follicle and keratinized tissue, which can explain some of the on-target, off-tumor adverse side effects that are seen with GPRC5D targeting therapies. And one thing also that's attractive about GPRC5D is that unlike BCMA, which is shed by the plasma cell in the form of soluble BCMA, there's no shed form of GPRC5D. So there's no potential for an antigen sink when administering GPRC5D targeted therapies. Another emerging target in multiple myeloma is FCHR5. So FCHR5 is also highly expressed on plasma cells and B cells, and with little expression on non-hematopoietic tissue as well. So little chance potential for off-target effects. And this is also being explored as a target with different immunotherapy constructs. So this is a summary of data to date with some of the non-BCMA bispecific T-cell antibodies currently in clinical development. And talquetamab is a GPRC5D targeting bispecific T-cell antibody with very mature data to date. It's actually undergoing regulatory review for potential regulatory approval later on this year, next year. And so talquetamab is administered subcutaneously, either weekly or every other week, and response rates seen that exceeds 70%, with majority of patients attaining a very good partial response or better. CRS is common, like BCMA targeted bispecifics, although high-grade CRS is rare. And then one thing I mentioned earlier was that we are seeing some unique adverse events with GPRC5D targeting therapies compared to other myeloma drugs. And so we see some dysgeusia, skin exfoliation, palmar plantar desquamation, and nail disorders. And this is likely due to the on-target, off-tumor adverse events of GPRC5D targeting agents, again, targeting keratinized tissue, given the expression of GPRC5D on these cells. RG6234 is another GPRC5D targeting bispecific T-cell antibody and now has a name, Farantamig. It's being developed initially as an IV construct, but now as a subcutaneous construct. Also, high response rates of 60 to 70%. CRS is common, high-grade CRS is rare, and the data is a little bit less mature with Farantamig than talquetamab. And then finally, cevostamab is an FCHR5 targeting bispecific T-cell antibody. It's given intravenously. Something that was unique both about Farantamig and cevostamab is that the protocol designs are for fixed duration. So, for instance, cevostamab, patients receive intravenous cevostamab for 17 cycles total on every 3-week dosing schedule. And over response rates are quite encouraging, almost 60% with cevostamab and data reported to date. CRS is common, but high-grade CRS is rare. And I think one thing that we're also seeing in data reported with all of these non-BCMA targeting constructs is that responses are being seen in patients with prior BCMA targeting exposure. So I wanted to spend a little bit of time talking a little bit more detail about talquetamab. So talquetamab is a GPRC5D targeting bispecific antibody. And this was studied in the phase 1, phase 2 pivotal Monumental 1 study. And so this phase 2 study was initially reported at ASH last year, and the New England Journal paper was reported from the phase 1 study results also last December. And so the phase 2 part of the study basically had 3 cohorts. Phase 1 looking at talquetamab 0.4 milligrams per kilogram subcutaneously weekly, talquetamab at a higher dose, 0.8 milligrams per kilogram every other week. And then there was also a cohort that allowed prior T-cell redirecting therapy, either with a bispecific T-cell antibody or a CAR T therapy, either at the 0.4 or 0.8 milligram per kilogram subcutaneous dose. And what was very nice to see was that this bispecific T-cell antibody had a very high over response rate, exceeding 70%, with the majority of patients attaining a very good partial response or better. And what was also very encouraging was that in that cohort of patients with prior T-cell redirecting therapy, the over response rates was over 60%. And so you can see here that some patients received CAR T, some patients received prior bispecific. We're seeing nice responses again in patients receiving prior T-cell redirecting therapy. In terms of the duration response and progression-free survival, the durability response is also quite encouraging. At the 0.8 milligram per kilogram subcutaneous dosing every other week, the median duration response was 13 months, and the median progression-free survival was 11.9 months. So I wanted to transition back to a case. And so this was a 78-year-old woman with relapsed refractory multiple myeloma, has had very long-standing multiple myeloma for many, many years. And the patient had initial presentation with anemia, later developed diffuse bone disease at a subsequent relapse. The patient had standard risk cytogenetics at a diagnosis and continues with standard risk cytogenetics, but the patient did have high-risk features, extramedullary disease at the time of more recent relapses. The patient has had 10 prior lines of therapy, and so the patient is refractory to bortezomib, carfilzomib, lenalidomide, pomalidomide, daratumumab, cyclophosphamide. The patient has had a prior BCMA targeting agent with belantamab mafodotin, which is a BCMA antibody drug conjugate. And the patient also received mezigdomide, which is a novel cell mod agent on a clinical trial. And so the patient would ideally have a bispecific CAR T option at this point. But in discussing options with the patient has a strong preference for the bispecific option. The reason why is because the patient lived alone, did not have a caregiver, and typically at MD Anderson for CAR T therapies, we do require the patient to have a caregiver for 1 month actually during the peri-CAR T period, given the risk of CRS or neurotoxicity. And so it logistically made more sense for the patients to receive the bispecific option. And so because the patient has received a BCMA targeting agent before in the past, albeit a BCMA ADC, the decision was made to proceed with an FCHR5 targeting bispecific T-cell antibody for the patient. The patient did well, had no CRS or ICANS with inpatient step-up dosing, with a best response of partial response, so duration response of approximately 4 months or so. So the last segment of this program, I did want to talk about some of the novel, and it really should say bispecific T-cell antibody combination strategy, not necessarily restricted to BCMA. And so looking at novel bispecific T-cell antibody combination strategies with both BCMA and non-BCMA targeting bispecific T-cell antibodies. And so I'm going to highlight 2 approaches actually based on recent data that was presented at this year's ASCO and EHA meetings. And so the first approach was data presented through the TRIM2 study. And so this was a study evaluating talquetamab, which is a GPRC5D bispecific T-cell antibody, in combination with the anti-CD38 monoclonal antibody daratumumab, which everyone is familiar with. And the rationale of this study was not only to leverage the anti-myeloma effect of daratumumab, in which it targets CD38 on the myeloma cell, but potentially it could help mitigate the immunosuppressive microenvironment that we see in myeloma patients by decreasing the number of CD30 expressing B-regs, T-regs, and MDSC. So potentially could prevent to allow for a more permissive microenvironment for the bispecific antibody to hopefully exert its effect. And so in this particular study, one of the key points of the eligibility criteria did allow patients who are refractory to daratumumab on the TRIM2 study. Patients receive talquetamab either at 0.4 or 0.8 milligrams per kilogram weekly or every other week with standard daratumumab dosing. And we saw was very, very encouraging response rates. And so 84% response rates with talquetamab 0.8 milligrams per kilogram every other week plus standard care daratumumab. And the median, and again, the responses also were seen in patients who are refractory to daratumumab. So you can see here on this table on the right that among patients who are refractory to daratumumab, 80% of patients had a response. So in terms of the durability response, the median progression-free survival was 19.4 months among 51 patients treated with talquetamab every other week plus daratumumab. So again, this appears to be at least a very efficacious, and actually I didn't show the safety data, but also a safe combination to consider in patients either refractory or sensitive to anti-CD38 monoclonal antibodies. So the last combination that I wanted to highlight was the Redirect 1 study. So this generated a lot of excitement at the ASCO and EHA meetings this past month. And the reason why it generated a lot of excitement was this is the first study that combined two bispecific antibodies targeting two different antigens. So basically, this study combined teclistamab, which is a BCMA targeting bispecific antibody, and talquetamab, which is a GPRC5D targeting bispecific antibody, and basically evaluated the combination both from efficacy and a safety standpoint. And in terms of the efficacy of this combination, the overall response rates were quite impressive. So at the recommended phase 2 dose of teclistamab 3 milligrams per kilogram and talquetamab 0.8 milligrams per kilogram every other week, the overall response rate was 95%. So actually was almost comparable to the response rate that we're seeing with cilta-cel, as we talked about earlier. So very, very high response rates. And we're seeing not only high response rates in all comers, but one thing to note on this particular study is that it did enroll a high number of patients with extramedullary soft tissue disease. So I mentioned earlier that in the previous sort of BCMA bispecific T-cell antibody studies, this has been a historically difficult subgroup of patients to treat, both in terms of over response, but also duration of response. So actually over 40% of patients that enrolled in a Redirect 1 study actually had extramedullary soft tissue disease. And among patients who had extramedullary soft tissue disease who were responsive valuable, 6 out of 7 patients had a response. So 86% of patients had a response. And so this was very, very exciting data to see such high responses in patients with extramedullary disease. And additional data will be awaited, of course, looking at this particular subset of patients. So I want to show a slide here summarizing some of the ongoing or planned phase 3 studies with some of the BCMA bispecific T-cell antibodies currently in development. And the main ones are with elranatamab, teclistamab, and linvoseltamab. So we talked earlier about some of the confirmatory phase 3 studies evaluating either teclistamab, elranatamab, or linvoseltamab with standard care triplet-based myeloma therapies, which are listed here. But something also to note is that there are also randomized studies looking at these agents in the maintenance setting. So looking at bispecific antibodies as part of maintenance therapy compared to standard care lenalidomide, but also newly diagnosed patients. And so there are trials again looking at, for instance, in magnesium-6, elranatamab, daratumumab, lenalidomide versus daralendex in patients with newly diagnosed myeloma who are not candidates for autologous stem cell transplant. So in summary, I wanted to discuss some of the advantages and disadvantages of bispecific T-cell antibodies. So the advantages is that it's off the shelf. And so the fact that it's off the shelf does not require apheresis manufacture prior to infusion of, for instance, CAR-Ts. Bispecific antibodies provide immediate access to patients in immediate need of therapy. And they also have very, very strong efficacy. For an off-the-shelf product, seeing response rates of 60 to 75% of patients is very, very high compared to historical overall response rates of single-agent therapies in multiple myeloma, and it's comparable to some autologous CAR T products. The disadvantage is that, at least for right now, the current protocols are all generally continuous therapy. And so continuous therapy versus a one and done versus CAR T therapy is a disadvantage. There's also some adverse events that we ought to watch out for. So as I mentioned, CRS is common. High-grade CRS is rare, but because of the risk for CRS, there is a step-up dosing strategy implemented for nearly all bispecific T-cell antibodies that do require some inpatient monitoring. And there's also drug and target-specific adverse events. So we are seeing a potential increased risk of infection with BCMA bispecific T-cell antibodies throughout different phase 1 and phase 2 studies. And I mentioned earlier the on-target off-tumor adverse events of some of the skin and nail toxicities and dysgeusia seen with GPRC5D targeting therapies. So what about future directions? And so really the future directions involve rational combination strategies. So I kind of highlighted a couple approaches in some of the earlier slides I showed. But one potential strategy is to combine it with IMiDs and cell mods such as mezigdomide or iberdomide to augment immune effector cell function, considering combining with immune checkpoint blockers to augment T-cell response, and this whole multi-antigen targeting approach as well. It's as seen in the Redirect 1 studies, like for instance, targeting GPRC5D and BCMA simultaneously seems to be a very promising approach in terms of both efficacy without too much increased safety concern. And then we also want to explore ways that we can maximize CRS mitigation strategies to enhance safety for earlier outpatient administration. I think this is going to be really, really key for the widespread adoption of these approaches, particularly in the community. And then also trying to find ways to maximize infection mitigation strategies, whether that be prophylactic antibiotics, IVIG, things like that, again, to mitigate the risk for infection. And then I think something of the future is to integrate resistance mechanisms, which I think will also play an important role in how we can sequence these agents, either CAR T or bispecific most appropriately. And then optimal sequencing strategies, where to use these agents as part of induction, consolidation, maintenance, pre or post CAR T. I think one area of research that people are very interested about is, these patients are achieving a very deep response. So can we do fixed duration therapies or response adapted approach at de-escalating the frequency of dosing, or perhaps even stopping therapy in patients with a deep duration of response? And then also then looking at multi-antigen targeted constructs. And so there are trispecific antibodies in development, and also NK bispecific and trispecifics also in development as well, that there's a lot of excitement about. So with that, I'll close my presentation.
Just a couple of follow-up questions. I think it was your third patient had extramedullary disease. Where was it?
It was in the scalp, actually. The patient had an extramedullary calvarial plasmacytoma.
So, like, when you say in the scalp, you mean in the skin or in the bone of the skull?
It was an extramedullary plasmacytoma associated with bone. So it was actually a soft tissue plasmacytoma growing outside of the bone, actually externally, actually. So it was actually palpable, actually, on exam.
Another question. The DARA, was it talquetamab study? What fraction of those patients had prior DARA, roughly?
It was, I believe it was majority of patients. It was, I think 80% or so of patients had prior DARA. So a majority of patients, it was a largely DARA refractory patient population that was actually enrolled on the study.
Another question, again, given the lack of direct comparison, but indirectly, how would you compare the risk of infection CAR T versus bispecifics?
This is a great question. So both carry a risk for infection, and I think that the risk for infection can sort of vary depending on the timing of the dosing, for instance. So CAR T therapy has a risk for infection, particularly immediately after the CAR T infusion. We know that there can be grade 3 and grade 4 neutropenia that can persist in about 40 to 50% of patients, even 1 month after the CAR T infusion, and so they can see prolonged neutropenia in some patients. So of course, in those patients, they're going to be at risk for infections in the immediate peri-CAR T period. Although this risk of infection, because of the one and done approach, does decrease over time. On the other hand, with bispecific T-cell antibodies, we don't see as profound cytopenias, for instance, compared to CAR T therapies, but we do see, for instance, particularly with BCMA-targeted agents, more profound humoral immunodeficiencies, and so we can see reduction in IgG levels in such patients, and potentially there's also the theoretical risk of T-cell exhaustion with continuous bispecific T-cell antibody therapy. And so I think over time with continuous dosing, we are seeing particularly an increased risk for infection with the BCMA CAR T therapies with continuous dosing, or BCMA bispecific antibodies with continuous dosing.
And in terms of this concept of response-directed therapy, which kind of, I think, sort of reminds me of intermittent androgen deprivation and prostate cancer, where you treat, you see a response, you wait, and you retreat. Is that something you ever do outside a clinical trial yourself? So any variation of that, dose reduction, holding it, anything like that?
Yeah, I think that dose modification is something that's is commonly used across myeloma treatment regimens. Just to give you an example, pomalidomide is a drug. For instance, the standard dose is 4 milligrams, but I have very few patients actually on pomalidomide at 4 milligrams that go to 3 milligrams or 2 milligrams or even 1 milligram. But the current paradigm for myeloma therapy has been continuous therapy, at least in the United States. And just because we know that myeloma is an largely incurable indolent B-cell neoplasm, essentially. And so the current paradigm is, again, continuous therapy. But there has not been ever really in the history of myeloma with agents as potent as bispecific T-cell antibodies or CAR T therapies. And so I think this is where we need to revisit that particular paradigm where we're seeing such deep, durable responses that are MRD negative sustained over a long period of time. And so, back to your original question, there are a few patients that especially patients who have had a response for a long time and want to break off therapy. And I think you think of myeloma, it's a marathon, it's not a sprint. So sometimes you need to sprint, I guess, in some sense, and be more aggressive with the therapy. And sometimes you got to take a little break, in the marathon. And I think that's okay. And I think another area that I think is a very hot area of research is a discontinuance of maintenance therapy. And so we have these patients who have sustained MRD negative CRs, lasting, 4 or 5 years, 6 years post initiation of maintenance therapy. And so I think those are patients we could also consider discontinuing therapy, and there's ongoing prospective trials looking at this approach.
Roughly in your view right now, how much of a problem are infections in people with bispecifics? Do most patients have problematic infections?
Yes, the infection risk is real with bispecific antibodies, and I think the data, especially generated and presented at the recent ASCO and EHA meetings, do suggest that there's probably an increased risk with BCMA targeting bispecifics compared to those that don't target BCMA, and this is probably related to the increased biological relevance of BCMA as a target compared to GPRC5D and FCHR5. So there's probably more profound humoral immunodeficiency with BCMA targeting therapies versus non-BCMA targeting therapies. And so this is something that needs to be taken very seriously. And so I think being very, very aggressive with infection mitigation strategies, whether that be, again, upfront prophylactic therapy. So we give all our patients prophylactic antiviral therapy, PGP prophylaxis as well with typically Bactrim. And then IVIG supplementation as well. And so our approach, at least at our institution, has been to give IVIG prophylactically up front if the IgG levels fall below 400. And so these have been measures, I think, that have helped a lot in mitigating infection. Even though vaccination responses are blunted in patients getting these therapies, we still highly recommend staying up to date on annual flu vaccines, pneumococcal vaccines, COVID-19 vaccines. And so these are also important mitigation strategies. But I think this is probably all the more reason why there's a lot more interest in de-escalating the frequency of dosing or even stopping therapy altogether in the future. The therapy has done its work. and let's just mitigate the toxicity long term.
So a final question is, if you could pick two or three questions you'd like to ask your colleagues about bispecifics, what would it be?
Yeah. So one thing that I think comes up is there's a lot of variation, I think, with standard of care teclistamab and how it's administered. And so, even though per the label, it should require 48-hour hospitalization, or inpatient observation after the first 3 step-up doses, how are people practically doing that? And there is some also flexibility in the package insert of when the step-up dosing can be done. So there's can be 2 to 4 days after the previous dose, not necessarily 3 days. So there's some flexibility. So I think knowing how people do it, I think would be interesting. The other thing is how do people manage CRS? And so, typically speaking, historically, we, especially in the CAR T experience, we have generally waited to give, for instance, tocilizumab until patients had grade 1 CRS for at least 3 days. But then there's emerging data of even using preemptive tocilizumab as a pre-medicine to mitigate CRS. And there's some institutions that give, the first sign of grade 1 CRS with a fever, there's some institutions that give tocilizumab up front. And so there's variation of that. So I think that'd be also interesting to hear opinions of how people do things that. And then I think the final question is sequencing. So sequencing of therapies. And so, by not just bispecific versus CAR T, but targets as well. As data mature, would some people even consider GPRC5D targeting therapy before BCMA targeting therapy or vice versa? And so I think sequencing is a major question in the future, how we'll go about that.
What about sequencing as it relates to other therapies? Of course, there are regulatory constraints on that, but if you could sort of take those regulatory constraints away, where do you think these bispecifics ideally would fit related to, other triplets that are often used in relapse disease?
Yeah, so I see, because of the high potency of these bispecific T-cell antibodies, I see them at minimum being used at the time of first relapse, so second-line therapy, whether that be a BCMA bispecific antibody or GPRC5D bispecific T-cell antibody. But of course, there are trials now looking at using these agents as consolidation. So in lieu of, for instance, of stem cell transplant. So, a patient gets standard induction therapy, and maybe they're a little more frail, so they might not be a candidate for a high-dose chemotherapy and autologous stem cell rescue. It could be a form of consolidation. But also now there's trials looking at using these agents up front, sort of like in the Maya trial with Dara and Dex, but instead,
Right.
for instance, using Dara, use a BCMA bispecific T-cell antibody. And I think, in these trials, especially using it up front, going back to your question of infection risk and toxicity risk, I think that's something that has to be carefully followed closely. And I think that the potential sort of carrot or advantage of doing a bispecific up front would be if a response is attained early, that's very deep and durable, it may allow for stopping or cessation of therapy early on. And so I think that would be the ideal scenario, is that get the response early on and then hopefully just stop therapy, after a year or two.
So the current approval for teclistamab is after 3 therapies?
After 4 prior lines of therapy.
4.
And they're triple class exposed to IMiD, PERS inhibitor, and anti-CD38 monoclonal antibody.
But for example, if someone gets DARA, VRD, transplant, and maintenance LEN, is that considered 4, or you need more than that?
Yeah, that's unfortunately considered 1, and so they have a long way to go. So it's
Wow.
plan
And that's really the reality?
Correct. And so the plan sequence, right, per consensus criteria, plan sequence of therapy. So induction, transplant, maintenance is 1 line of therapy. And I think this is actually a great point you bring up, Neil, is that, I think historically speaking, we've defined regulatory approvals based on lines of therapy. So 3, 4 lines of therapy. But unfortunately, particularly in patients with high-risk disease, they need these treatments earlier than 4 prior lines. They're not going to make it to 4 prior lines, before getting these agents. And so I think something else to look at is that's more relevant is refractory status. So what agents are they refractory to? So if a patient, for instance, is refractory, triple class refractory after 2 prior lines of therapy, that patient, should be able to get these therapies. And so I think hopefully in the future, the regulatory agencies and how trials are designed will focus more on refractory and exposure status rather than the number of lines of therapy.
So if you could use teclistamab whenever you would want to use it, when would you use it in a younger patient who gets a transplant and maintenance? After
So
one more therapy, or would you use it right then?
yeah, I mean, I think if I had a patient with a short duration of response after first line therapy that had functional high risk disease or high risk disease based on FISH studies, we know that outcomes in high risk disease are not great with standard therapies. And so I'd be aiming for either a BCMA CAR T or bispecific at that point. And so hopefully, the regulatory approvals will change in the future based on the readouts of some of these studies. And I think one thing we didn't talk about was the CARTITUDE-4 data that was presented as a plenary at EHA and as a late-breaking abstract at ASCO, and very, very exciting data of seeing the efficacy of cilta-cel versus standard of care triplets.